one of our families and patients have asthma, how well controlled it is. It is a big aspect of food allergies. So we thought through this talk, we can kind of explain some of the research and evidence behind the link between food allergy and asthma and how we kind of look for it within our clinic. So, you know, any of you who have been part of our trials can understand why we do some of these tests and just kind of long-term, you know, what we worry about long-term, and just kind of share our insights with you and address any questions that may come up. And my name is Tina Sindher. I'm one of the associate professors within the Shannon Parker Center for Allergy and Asthma Research, and I'm the principal investigator on a lot of these trials. And I do outpatient pediatric allergy clinic as well. And thank you all for joining us today for this discussion. And Tina, do you think now is a good time to have a sense of who our audience is in terms of asthma history?
Yeah.
Yes.
See the shared data.
Yes, I see it. That's okay. So looks like 65% of our attendees today have a family member who has asthma and food allergy. So this will be hopefully, we'll learn something new through this talk today, hopefully. Alrighty, next slide, please. All right, so along with most other atopic conditions, and when I say atopic, I mean food allergy, asthma, eczema, environmental allergies, the prevalence of asthma has been growing at a different rate in different countries. So it is rising in the low and middle income countries and plateauing in high income countries. An estimated 300 million people worldwide suffer from asthma, with 250,000 annual deaths that are attributed to be caused by asthma. The numbers of asthma are projected to continue growing and will be more than 100 million of the worldwide population by 2025. And what's key is that 70% of asthmatics, that most asthmatics have allergies, concurrent allergies as well. Next. So just a quick kind of visual overview of what we mean when we say asthma. On the far left here is the normal bronchus. And if you see the numbering there, there's the cartilage. Number 2 there is the open airway. Number 3, the little dots on the side there are mucus glands. And number 4 is the muscle layer surrounding our bronchus. And during inflammation, what we see is the mucus glands produce excess mucus, and they kind of fill in the opening of the airway and constricts the airway, and the muscle layer contracts, and you can see hypertrophy there. So with kind of prolonged bronchial constriction, the muscles tighten and the alveoli are filled with trapped air, and this all kind of leads to the symptoms that we see with asthma. Next slide. So this is again another visual representation. With folks who have chronic asthma, and during kind of inflammation, we see hypertrophy of the mucus glands. That's because they're overproducing mucus. There's edema and inflammation, mucus within the open airway. There is epithelial damage, and then smooth muscle hypertrophy, just because they're constricting so much. The inflammatory cell infiltrate kind of fill the area, and these are basically caused by eosinophils and lymphocytes. Neutrophils are also a big part of asthma, severe asthma, but in our allergic asthmatics, we see more eosinophils, and dilation of the vasculature. Next slide, please. And so the way we diagnose asthma, and in our kind of clinical research world, definition of asthma and essentially means that there's chronic airway inflammation. Patients or participants, they have respiratory symptoms such as wheezing, shortness of breath, chest tightness, and cough. So any of you who have been to our center, you've probably been asked these questions every time you stop by. And then in addition to the symptoms, we see this variable expiratory airflow limitation. What that means is that if we were to do a pulmonary function test where we assess your lung function, we will see limitation there. And that's part of how we define asthma and diagnosis. And there's also airway hyperresponsiveness. That means that if we were to treat with albuterol or controller medication, it will improve. And it's just very, we call them twitchy lungs. They're very responsive to treatment. Next slide, please. So there have been so the link between food allergy and asthma is there in the sense that numerous studies have been presented over many years that kind of confirm this connection. And I wanted to use this opportunity to just present some of these numbers to show our audience how prevalent this is. So, in a birth cohort study of 562 children, they found that those with early food sensitization, so they were diagnosed with food allergy at 3 months to 18 months of age, they were at a significantly higher risk of developing asthma by the age of 6 years of age. In a study done in Israel with over 11,000 adolescents, they found that between 13 to 14-year-old participants, those with food allergy also had severe asthma compared to those without food allergy. In another study, where the authors surveyed 300 asthmatic children, among whom 24% had food allergy and many had multiple food allergies. Those with a food allergy had a much higher risk of hospitalization compared to those without food allergy. Again, another study looking at over 200 asthmatic children between the ages of 3 months to 14 years. They divided this group into kind of subgroups, those with asthma and food allergy, and those without food allergy. And they found that the coexistence of asthma and food allergy was associated with an increased number of hospitalization and a greater need for systemic steroids. So essentially, for our asthmatics, the existence of food allergy leads to more severe asthma with a higher risk of hospitalization, greater need for steroids. Next slide, please. So as food allergy can make asthma more life-threatening, asthma also increases the severity of food allergy and increases the risk of anaphylaxis. So the flip has also been seen. In a study conducted on 88 children with allergic children with cow's milk allergy, they found that the frequency of more severe reactions was 10 times greater in children who also had asthma. And then another study where they looked at fatal cases of anaphylaxis through a national registry, they found that among 32 fatal cases, 31 of those cases had pre-existing asthma. So asthma was a common denominator in majority of these fatal events. So they kind of work together in worsening the other. So asthma is a risk factor for more severe food allergic reactions, and the existence of food allergy is a risk factor for more severe asthma exacerbations. Next slide, please. So I wanted to review some of the data we have found within our center. So our team had published this paper a few years ago based on food challenge data. They attempted to develop a tool to predict severity of food challenges that we see. So medical history and allergy test results were reviewed for 120 peanut allergic participants who underwent double-blind placebo-controlled food challenges as part of our clinical trials. And for those of you who may not be familiar, double-blind placebo-controlled food challenges basically means that as part of entry criteria for a food allergy study, we have the patients undergo oral food challenges, but we don't know which day is which. There's one day with peanut and one day with placebo, and the term double blind means that both the participant and the team then the investigator team does not know what the patient is receiving that day. Next slide, please. So the reactions were assigned a food challenge severity score between 1 and 6 based on kind of what the cumulative tolerated dose was. So essentially, how much did they tolerate before they had a reaction? And there was a severity clinical indicator based on what kind of reactions they presented with. And then demographic characteristics, clinical features, meaning how they presented, peanut IgE values, and basophil activation markers were kind of used and considered in a multi-step analysis to come up with a tool to understand risk of severe reactions during oral food challenges. Next slide, please. So using classification and regression trees, also known as CART, and this was done by our fabulous statisticians, 3 features were used to classify participants and assess risk for severity of reactions. So among the 120 participants who were enrolled, 18.3 participants were thought to have severe reactions, and the decision rule algorithm identified 3 variables as predictors of reaction severity. One of them was a marker for basophil activations. That's the CD63 stimulation. But what was interesting is having a history of exercise-induced asthma and the value of the forced expiratory volume in 1 second to forced vital capacity, or the FEV1 over FVC ratio. I'll briefly touch on that later, but this is something we assess during every food challenge whenever we ask our participants to do a pulmonary function test or spirometry. So essentially we found having exercise-induced asthma or having a low ratio was associated with more severe reactions. And these are, our participants who come into these trials generally have very well-controlled asthma, if not mild. So that was interesting within our group. And then I just wanted to touch briefly on how we monitor asthma at our clinic. So if, for those of you who are familiar or have participated in our trials, you'll know that we frequently ask you, have you been coughing? Do you take controller medications? Have you been hospitalized? Any wheezing? And then for some studies, we perform spirometries where we have you breathe through a machine to understand kind of how your lungs look. And based on these values, we can kind of keep track of how your lungs are doing and whether we need to be worried about any elements of asthma. And then the peak flow meter there is something we use a lot prior to updosing visits or food challenges, which many of you may also be familiar with. Next slide, please. So another reason I actually wanted to discuss asthma today in the setting of food allergy is as we kind of see a lot of natural kind of world events taking place in terms of drought and fires and storms, in these kind of environmental events also increase the risk of asthma exacerbations within our community. So studies in the past have shown that during times of smoke exposure through pollution or wildfires, asthma exacerbations significantly increase during these times, as well as kind of hospital visits and emergency room visits. Next slide, please. And then what we have actually noticed is that over the years, pollen counts have been increasing, and they are directly associated with kind of the level of carbon dioxide. And prior studies have shown that as pollen counts are increased, the rate of asthma exacerbations increase as well, because a lot of our asthmatics are allergic asthmatics, and they have environmental and pollen triggers for their exacerbations. Next slide, please. We've also found that exposure to ozone can also worsen asthma, and there has been a projection of worsening asthma over the years that has been attributed to increased ozone concentrations. Next slide, please. And then extreme heat and precipitation events are also associated with increased risk of hospitalization for asthma. In the study done in Maryland, they looked at over 100,000 ER visits, and they concluded that there are projected increases in frequency of extreme heat, which will have an impact on public health and lead to more asthma exacerbations and hospitalizations. So, our research center focuses primarily on food allergy, but food allergy doesn't come alone. Most of our food allergic families and patients have a concurrent history of eczema, of seasonal allergies, of asthma, and these are all the other health conditions that we have to keep an eye out for and help manage and control, because they don't come alone. They come kind of together, these conditions. And the reason as with the increase of our air quality index getting higher with air quality being affected with wildfires, we have actually had some cases of anaphylaxis where, after exposure to smoke, walking outside, even though a participant has been completely well controlled on their maintenance dose, they can have an allergic reaction. So this is something we are seeing, and the advice we give our families is that if they're food allergic and asthmatic, being safe in terms of exposure to air, clean air is even more important, in the sense that severe anaphylaxis and asthma exacerbations can be life-threatening. Next slide, please. So now that we've talked about all gloom and doom, I just wanted to throw out there all the different studies our center is actively participating in. Although there is no asthma specific study listed here, that is something we have worked closely with in the past, and are trying to include our digital health or remote monitoring tools to kind of monitor lung health and lung function remotely through Bluetooth devices. So that is something we are trying to move forward with. And also, we have numerous kind of prevention studies in the works, namely our SEAL study and Sunbeam study, where we're going to follow infants or birth cohorts. And we're hoping that through these long-term birth cohort studies, we will have a better understanding of prevention strategies and what we can do to kind of, de-link asthma and food allergy, and hopefully just kind of prevent it from developing in the first place. Next slide, please. And here, I think all of you probably already know by now how to get a hold of us. And if you have any questions or want to explore what kind of studies we have, or want to just reach out to us with questions, we're happy to kind of help there and share our insight. And that's actually it for today. And I'm happy to review and answer any questions.
Thank you so much, Dr. Sindher. We have a couple questions. Can I read it to you?
Yes, that sounds good.
Yeah, so as with food allergies, there are early interventions to help reduce the likelihood of developing food allergies. Are there any interventions for asthma?
Yes, that's a great question. And this is actually something we are hoping to learn more of through our SEAL study and Sunbeam study. And essentially there is this, we may have spoken about this last time. I think it's this concept called Atopic March, where we think that all of this can kind of start at the onset with kind of epithelial barrier defect, meaning our skin is not as pristine as we would like it to be, and then we have allergen kind of entering through breaks in our skin. And by breaks, I mean kind of dry skin, eczema, anything that kind of compromises the natural barrier can set us up for sensitization, meaning that it kind of primes our the arm of our immune system that makes us likely to develop an allergy to something. And these allergic sensitizations early on, either food or environmental, is what kind of sets the stage for long-term development of asthma, food allergy, seasonal allergies, and the work. So if we can figure out how to block that initial entry and sensitization, I think we'd be able to not only block food allergy, but also asthma. But we'll know more as more and more studies explore this specifically.
The next question I have is, for those with asthma who receive steroid medications to treat it, is there any connection with severity of food allergies? And then the second part is long-term use of steroids linked to increased in food allergies?
That's an excellent question. So untreated asthma, so as I mentioned, it's basically a chronic inflammatory state within your lungs. If we don't treat it with steroids, you kind of lead to this process of muscle hypertrophy, this hypertrophy of the mucus glands, and the airway narrowing. So what steroids do is kind of block that process, and it just makes the lungs function better. So if anything, I think aggressive control and proper management of the airway for asthmatics will help kind of prevent severity of food allergy reactions. So we have not seen that use of steroids for asthma, inhaled steroids, would affect long-term development of food allergy. If anything, it makes it well-controlled asthma is a good thing in the setting of food allergy.
The next question says, besides the correlation between food allergy and asthma, is there a physical biochemical reason for this correlation?
Yes, that's an excellent question. So our immune system is kind of on this, it helps me to think of it as a seesaw. On one side of the seesaw is, I call our Th1, or kind of tolerant arm. And then the other side of the seesaw is our Th2, or kind of our allergic arm. And what happens early on in a child's life, and a lot of this, we're still learning more and more. So it's not, this is what we understand, is early on, allergic individuals tend to be more Th2 skewed or allergic skewed, and they tend to have higher numbers of IgE, specific IgE. They tend to have more eosinophils and lymphocytes, and these are the kind of the markers that lead to allergic disease. And we can kind of see this Th2 pathway play out in all these allergic conditions, namely eczema, allergic rhinitis or seasonal allergies, asthma, food allergy. And because there's this shared immune pathway for these, we've actually been able to use a lot of biologics that have been approved for eczema or asthma in the setting of food allergy, because they kind of help all of those atopic conditions.
Thanks, Tina. The next one is, can any of the clinician trials be done remotely for those who live far away from Stanford?
Yes, that's a great question. So we are, through our kind of digital health initiatives, we are trying to find ways to offer studies for families who live far away. And this really, we're trying to see if we actually did submit a proposal where we were trying to do a peanut allergy study, where the visits would be done through telemedicine. We could send, Bluetooth enabled devices with the family, where, they would just perform the procedure through, Zoom or some other telemedicine interface, and we'd immediately get the results onto our system and kind of assess how they're doing. We would monitor up dosings, and even kind of we're looking into microsampling, where we can kind of mail supplies to families, and they can kind of draw blood on their own and send it to us so we can kind of monitor. So we don't have anything active now, but this is definitely something we are looking into to make this available for more and more of our families.
Thank you, Tina. Do you have time for one more, or?
Yes, one more, please. And the
Okay.
rest, whatever I don't get to, I'm happy to respond back via email.
Okay, so we have an anonymous one here. It says, is there anything we can do besides treatment with albuterol, if I'm pronouncing that correctly, before exercise to control exercise-induced asthma?
I'm so sorry. Would you mind repeating that one more time?
Is there anything we can do besides treatment with albuterol? Is that
Albuterol,
yeah,
yeah.
albuterol before exercise to control exercise-induced asthma?
So it depends on how severe the asthma is. For some of our families where they are otherwise well and they don't really have any issues or concerns and their asthma is well controlled, no ER visits, no shortness of breath outside of exercise. And if pre-treating with albuterol alone is keeping it under control, then that's great. We don't have to move further along. But if they find that it is holding them back, or, they are waking up at nighttime with coughing, or when they have viral infections, the symptoms are prolonged and the cough just takes a while to get better, or if they've needed oral courses of steroids, like prednisone or something, versus just the inhaled steroid, then I think it may be worth adding, the controller medication. A lot of asthma management is really kind of, there's no one size fits all. It really depends on how the patient is doing. And so there are times when I will up the medication, during pollen season or back to school time, but then during the summer they're better and we'll kind of go down on it. So we can play around with the dosing to make sure that the person can, perform at their best without being held back by asthma symptoms. So long story short, if albuterol works, great. But if more care is needed, then we recommend stepping it up to include more medications.
All right, thank you, Dr. Sindher.
Thank you so much. Thank you, everyone. Bye.